Okay. Right. Hello, everyone. March is Ovarian Cancer Awareness Month, and we at the Surrey Park Clinic wanted to do our bit to raise awareness of ovarian cancer. It's the sixth most common cancer for women, as far as I'm aware, but I have an expert with us today who's going to introduce himself, and we'll talk about everything to do with ovarian cancer. So, Jay, could you introduce yourself for us, please?
Hello, I am Jay Chatterjee. I'm a consultant gynae oncology surgeon, and I chair the Surrey Gynae Oncology MDT as well. I trained at Hammersmith and hold academic posts at the Imperial College as well as University of Surrey. I'm a robotic, laparoscopic, open radical surgeon and treat women with all gynecological cancers.
Yeah, and you're one of our brilliant consultants at the Surrey Park Clinic as well. So shall we just kick off, if you could just give us an overview of ovarian cancer and just let everyone know exactly what it is and who's at risk.
Ovarian cancer is always said to be a silent killer. And that's primarily because the vast majority of women who come to see me with ovarian cancer, unfortunately come to see me at an advanced stage, so which is stage 3 and 4. And that's again because the organ that we're talking about, that's your ovaries, are quite deep-seated in your abdomen and your pelvis. So by the time it starts giving you symptoms, it's already enlarged with a tumor, it's causing ascites, it's spread to your liver, it's spread to your bowel, it's spread to your spleen, and possibly even the lining of your lungs called the diaphragm. However, as we have understood this disease more and possibly understood its origins like we have never done before in the last 4 to 5 years, we understand that actually this disease has been difficult to pick up at an early stage because we were targeting the wrong organ. Although the term is ovarian cancer, actually most of the high-grade advanced stage cancers that we deal with arise from the fallopian tube. And hence the stage shift that we talk about from stage 1 or even pre-cancer to stage 4 does not happen because we are looking at the wrong organ. So we have now become quite clever. We look at early presentations. I give a lot of educational talk to GPs and make them aware, as well as to charities and patient-focused groups, to make people aware of these symptoms, which can be non-specific to the unknown. But if you're getting things like bloating, abdominal pain, vaginal bleeding, frequency of urination, loss of appetite, nausea, it may not be bowel related. It could be your ovaries playing up. So just yesterday I was giving a talk to a group of GPs, asking them that the first line of investigation for these group of women with such non-specific symptoms is not to do certain blood tumor markers, but to do a good transvaginal scan by an expert or a well-skilled sonographer to look at their ovaries and characterize and see if there's any abnormality there. So we are moving along the diagnostic pathway where we are trying to pick up things at a much earlier stage. We are trying to treat the disease much better in the last and staging these cancers much better with new modalities of MRI, CTs, even laparoscopies, and we are far more radical in our approach. So as we have subspecialized and super specialized into gynae oncology specialist cancer surgeons, we operate in a different way these cancers, as we now know that when we operate on these patients, leaving behind no residual disease is the best prognostic factor. So it's not uncommon for me to operate for 5 to 6 hours on ovarian cancer women, not only operating on their gynecological organs, but also operating on the bowel, on the liver, on the spleen. But at the end of the surgery, they have almost no visible or no disease that is visible to the naked eye. And hence we do what is known as a total clearance with nil residual disease. And we know if we achieve that, the survival benefit is significant in terms of years and months in improving the survival. So surgical approach has changed. We are having new chemotherapy drugs. Now we know that every woman diagnosed with ovarian cancer is being BRCA tested. So we're not only looking at germline mutations, we're looking at somatic mutations, which is the presence of the BRCA mutation in the tumor. And hence, we can offer them new treatments like the PARP inhibitors, which has made a huge difference in survival, both overall and progression-free survival. So we are trying to attack this disease, if you like to say that word, in all fronts, in better diagnostics, in better therapeutics, in better maintenance treatment, improving quality of life. In our center in Guildford, we're also looking at robotic modality of operation in certain ovarian cancer patients, and also prevention. So patients with known BRCA mutations are being offered risk reduction surgeries. We are even doing 2-stage procedures for very young women where we remove the tubes initially, allow them not to go into premature menopause, and then when they have reached 40 and beyond, we talk about removing the ovaries. So a lot is going on, and there has been a significant improvement in survival from ovarian cancer just in the last 5 years.
Okay, thank you. Jay, just for those women who may not know about BRCA mutations, do you just want to talk a little bit about that?
Sure. So we now know that ovarian cancer can be genetically inherited due to certain gene mutations, where you have got abnormal genes mutating in your body, which you've inherited from your parents. And BRCA is one of those genes. There's 2 types, BRCA1 and BRCA2. Both these gene mutations are associated with an increased risk of ovarian, tubal cancer, as well as breast cancer. And BRCA1 also very minimally increases your risk for uterine cancer. So these are inherited genes. There are a few more, PAL-B, etc., that we are trying to understand better. And as genomics is expanding and we are trying to understand and do gene mapping and understanding genomic atlases, we are trying to understand better and better these kind of inherited gene mutations, which make a person more at risk in developing these cancers at a much earlier stage in life than the general age-related somatic mutations that happen with old age, which makes you prone to get cancers.
Thank you. And so in talking about the most common age to get ovarian cancer, from my understanding, it's mainly women over 50, is that right? Or
so ovarian cancer is actually a very broad term. When we talk about ovarian cancer, I think we mainly talk about epithelial ovarian cancer, which I think is what you're talking about, Jules. But we have some non-epithelial cancers like germ cell tumors, sex cord stromal tumors, and other tumors which can happen in a much younger age group, in the 2nd and 3rd decade of life. The classical ovarian cancer, which is the epithelial ovarian cancer, mainly the high-grade serous, which predominates as 90% of all ovarian cancers, happens in the 5th, 6th, and 7th decade of life. So you're right with that. But we are seeing slightly an age shift where even women in their late 40s are getting ovarian cancer and the high-grade serous ovarian cancer.
And they might not be because of BRCA, that just might be those type of cancers are slightly younger skew, is that right?
That's right. So the cancers that happen due to the BRCA mutation, you're absolutely right, happens in a younger age group, whereas the non-BRCA ovarian cancer is due to somatic mutations, predominant, largely is much later in life, but we are starting to see some of them also in the late 40s, early 50s, etc. But we have to understand that cancer is multifactorial, and you can have a mismatched DNA repair where one gene has gone faulty or one repair mechanism has gone faulty, causing a rogue cell to then transform into a cancerous cell. And the ovaries are a very heterogeneous group of cells that make up that organ. So you have not only the epithelial cells, you have the non-epithelial cells, you have the mucinous cells, etc. You have women who have got a background history of endometriosis, which makes them at slightly higher risk of getting ovarian cancer later on. So, ovarian cancer is multifactorial.
Mm. Gosh, we're finding more and more out about it though, so it's very interesting. Are there any sort of lifestyle factors that make people more at risk of ovarian cancer, or not? Is it just random? Obviously, excluding the BRCA mutations.
Those are inherited mutations. I mean, there seemed to be a slight increase with the use of HRT if given in an unregulated way at a later stage, but the increase is very minimal.
Mm-hmm.
Nothing like the risk that is associated with breast cancer and uterine cancer if you give unopposed estrogen at a later stage in life. There is some association rather than risk where increased BMI, so these are usually estrogen-driven cancers. So if you have a large body mass index where you have got peripheral conversion of fat causing more estradiol in your blood, that can drive ovarian cancer. Nulliparity, so women who have never been pregnant before, they are at a slightly increased risk for breast cancer. People with endometriosis, we have talked about, there's some evidence coming through where polycystic ovarian disease might be associated with an increased risk, probably due to anovulation, etc., etc. So these are some of the things, but obviously leading a healthy lifestyle, keeping a normal body mass index, and doing the right things are always good in preventing getting cancer.
Yeah. Okay. Brilliant. I think you've already touched on the symptoms. You talked about the bloating and maybe the bleeding. So they seem to be the main ones, don't they? And obviously they can be related to lots of other things, but it's good to get that checked out. If those symptoms, is it over a certain period of time that you should go and see the doctor? Is it like if they've been happening for a few weeks?
Yeah, I think if you are experiencing bowel disturbances, if you're feeling bloated, if you're getting pelvic pain, if you're feeling nauseous, and that's going on for weeks and months, then don't ignore it. If you feel that your abdomen is getting bloated, you're getting satiety where you feel full after a little meal, and that's happening over weeks and months. If you're feeling pressure on your bladder, you feel that your bowels are not working well, then don't sit at home and just ignore it, thinking, oh, that's a bit of irritable bowel or something like that. Please do go and get checked by your GP. And as I said, that it just takes a baseline good transvaginal scan to assess those organs and make sure they're all fine.
Yeah. Okay. And obviously at the Surrey Park Clinic we do that, don't we? We've got the pelvic the sonographers doing the scans.
That's right. We have got I do my own scans, and we've got sonographers doing high level pelvic scans. We offer the whole ovarian cancer screening where we look at all the tumor markers, and we do a whole women's health screening program at Surrey Park Clinic assessing these things.
Yeah. And so that's the CA125 blood test. That's included in that, isn't it?
Right. So the CA125 is included in that, but it must be properly interpreted, because CA125, although NICE says that as a primary investigation, unfortunately it's a tumor markers which is non-specific. So the specificity is about 56%, although the sensitivity is quite high, almost 85%. So, which means that it can be raised in many other conditions. So just doing the blood test is not the right way. It needs to be correlated with symptoms, scan findings, etc.
Right. Okay. Brilliant. And then if someone was to come for ovarian screening at Surrey Park Clinic and something was found, what would be the next steps for them?
So I think, we offer rapid diagnostics and then escalation depending upon what the scan findings are and what the tumor markers are. Usually they'll come and see me, and then being part of the Royal Surrey Gynae Oncology MDT, we get these patients investigated by MRIs, and if there's a concern that this is looking cancerous, we take our patients to the MDT, which is a panel of experts. I chair that MDT for Surrey, but it has got 3 other consultant surgical colleagues. We've got oncologists, radiologists, pathologists, and various team members who are real experts in this field. So we all put our head together and make a plan. Each plan is individual to the patient's requirements. So if it's a patient who is very young, which is fertility preservations, we talk about surgeries catering to that fertility preservation. If the patient has completed their family, we talk about doing the surgery, taking that into account. We offer intraoperative frozen section, which is intraoperative histological diagnosis, where if the mass is indeterminate and we're not absolutely sure because it doesn't have the bond or hallmark features of cancer, while I operate, I take out the mass and send it to my pathology colleague, who's an expert at this, and will tell me in the next half an hour while I operate on the patient the nature of the mass, so I can cater the surgery according to that nature and adequately stage the disease and treat the problem at the same time.
Right.
So these are the next steps where the treatment is decided by a panel of experts, and then we carry out the surgery. And if it is ovarian cancer and if it's beyond the ovaries, then usually these patients go on to have chemotherapy. And again, in Guildford at St. Luke's Centre, we've got an excellent chemotherapy unit where we can cater and we can give all the latest drugs like PARP inhibitors.
Brilliant. Okay, well, I think that's brilliant. I think we've raised awareness of what to look out for if you're worried, which is the key thing for March Ovarian Cancer Awareness Month. And that was really interesting, getting all your insight into the ovaries and how complex it all is. So thank you ever so much for that, Jay. That's been really informative. I hope that's helped everybody. Thank you.